Ladies and gentlemen, my name is István Baradács, and today I would like to present you my progress on my PhD topic, which is the targeted therapy in ovarian cancer. Let me introduce our team. I'm a resident doctor at the Department of Obstetrics and Gynecology at the Semmelweis University. My supervisors are Balázs Lindner and Ferenc Bánhidi. My vision is that the molecular targeted treatment could completely change oncological therapeutic pathways, and the mission behind my work is to learn about the possibilities given by the individualized molecular therapies and bring the knowledge back to the bedside. We have two projects. The first one is investigating the efficacy and safety of PARP inhibitors in advanced ovarian cancer, and the second one is investigating the combination therapy of PARP inhibitors and anti-angiogenic drugs in advanced ovarian cancer. Let me start with my first project. I would like to give you some background. Advanced ovarian cancer is diagnosed at an advanced ovarian cancer diagnosed at an advanced stage in 75% of the cases, and with standard chemotherapeutic treatments, relapse occurs in 70% of the cases. These facts highlight the need for a new effective therapeutic solution, and based on recent clinical trials, PARP inhibitors could be this. Our aim is to assess the efficacy and safety of PARP inhibitors in advanced ovarian cancer. The clinical question is, do this PARP inhibitor therapy provide longer progression-free survival for our patients? The patients are newly diagnosed and recurrent relapsed ovarian cancer patients. The intervention is the PARP inhibitor therapy. The control is the placebo or chemotherapy. Our outcomes are progression-free survival, overall survival, and adverse events. Our hypothesis is that the PARP inhibitors provide a better progression-free survival. We ran our systematic search, and we found 21 eligible full text for our meta-analysis. I would like to continue with the results. Here you could see the progression-free survival in recurrent and newly diagnosed ovarian cancer. This is an aggregated forest plot with pooled hazard ratios. On the left side you could see the therapeutic settings, and after the forest plot with hazard ratios, the statistical heterogeneity and the graded certainty of evidence. As you could see, in almost every patient population, in every therapeutic setting, we found a statistical and clinically significant progression-free survival benefit with the PARP inhibitor therapy. And the next slide for the results part are the adverse events, which are the most used parameters of measurements of tolerability, and it's shown in the newly diagnosed ovarian cancer patient population. It's quite obvious that with the added PARP inhibitor therapy, the risk and the number of adverse events is increased compared to placebo, and the myelosuppressive and the hematologic toxicity of these drugs are well known. But the good news is that we found out that these adverse events was manageable and handled with dose modification instead of therapeutic discontinuation. As we arrive to the summary, I would like to mention the strengths and limitations. Our meta-analysis is based only on RCTs, and we had quite homogeneous populations. We have some clinically important results in subgroups, and overall the risk of bias was low. On the other hand, there are some limitations. In the intervention, there were some minor differences, and most of the cases, the overall survival data was unmature or unavailable. And the overall follow-up time for the studies was quite short at the time of the meta-analysis. As a conclusion, PARP inhibitors demonstrated a huge benefit in progression-free survival. On the other hand, they increased the serious adverse events, but found manageable and safe at the same time, because I will show why. The treatment of the primary and the recurrent ovarian cancer both could be handled with PARP inhibitors, and adverse event management for the clinical question is done by dose reduction, as I said. There are some unanswered clinical questions, like we don't really understand. We got theories, but we're not sure about the progression-free survival prolongation in the BRCA wild-type patients. The best timing for this PARP inhibitor therapy is questionable, and if we won't have benefits with the PARP inhibitors alone, we should turn our face to the combination therapies with other targeted treatments. Okay, so the first manuscript was submitted for the second time to the Journal of Ovarian Research in February, and I would like to continue with my second project. It's quite the same project for the structure of the project, but it's investigating the combination of PARP inhibitors and anti-angiogenic drugs in the ovarian cancer. So as I said, this disease is characterized by late diagnosis and high relapse rate, and in addition there are limiting factors for standardized chemotherapy, like the platinum sensitivity, neurotoxicity, and myelotoxicity. And this kind of combination could hold the potential for the future to have a chemotherapy-free therapy for these patients. Our aim is to assess the efficacy and safety of the combination therapy. Our clinical question is, do the combination provide a better progression-free survival? And the patients are advanced ovarian cancer patients too. Their intervention is the combination therapy. The control is a PARP inhibitor or chemotherapy, and the outcomes are the same as the previous one. I finished the manuscript for my second project, and with the revision of my supervisor and SMS, we will send it to internal review in this month, in July. Here I would like to present one of our result slides. In this slide, the progression-free survival is shown in recurrent ovarian cancer, and as you can see, in the left side there are the therapeutic settings, and for the BRCA wild-type patient population, the use of the combination therapy compared to PARP inhibitor alone was beneficial in the aspect of progression-free survival, and this is the most important statistically significant result of our second project. We submitted our first project in December, and the planned submission time is July, not February, for our second project. I'm so proud and like to mention that the students of our project, especially Vince Adam, who made the rectorial thesis and got a special prize connected to our first project, and he also also hold a lecture at the student research conference in 2023. Okay, I would like to close my presentation with the quote of Hippocrates: wherever the art of medicine is loved, there's also a love of humanity. Thank you.
First, if you go back to your first project, and you showed a few forest plots, I didn't really understand here and in the next one. This is hazard ratio, and the next one is relative risk, right?
Yes, risk ratio.
So what is the model here, and how are they constructed?
so these are pooled hazard ratios, and for each of these outcomes, there are separate forest plots with the.
And so these are separate random models.
It's an aggregated, yes.
Okay.
Yes,
Okay.
yes, it's an aggregated. That's how it looks in a manuscript. But for this project, we got approximately 80 forest plots. So we had to organize them somehow, and that was our solution.
Absolutely fine. Fine. I'm just saying that if you present it this way, somehow make it clear that this is an aggregate of all the outcomes. So this is because initially it looks like as if it's one model with in a multivariate setting. Okay, so these are all of these estimates are individual models.
Yes, these individual results.
And why relative risk in the next one? Why not odds ratios or risk ratios? Yeah.
No. It's risk ratio.
Yeah. But why?
We use this because in every article that we chose, they used this type of. Okay, I know that we could use odds ratios too, but risk ratios are more handy to presentations, and that's the most frequent measure of adverse event.
And these are all RCTs then?
These are all RCTs, yeah.
Okay.
It was 14 RCTs and 21 articles because of the follow-up times were different.
Okay. And the second larger topic is in your second project's forest plot.
Oh, sorry. It's not an aggregated forest plot.
Yeah, that's not an aggregated from the forest plot.
Yeah.
So here you have basically 3 papers, right?
Yes. In the whole project, there are only 7 RCTs, and we divided it to. We had to divide it to subgroups because the newly diagnosed and the recurrent ovarian cancer couldn't be put together. And the other thing is that in some of the RCTs, in this case, they compared the combination therapy to PARP inhibitor alone. But there is another line of this investigation where they compared the combination therapy to chemotherapy alone. So we decided to do subgroups and.
Okay, but the question is, for instance, if you take Mirza et al. 2019, the 48 versus 49 patients, is that the ones below, is it a subset of that 48 patients?
No.
So these are separate.
The whole population.
Okay.
Yes. Because, yes.
Nonetheless, did you treat somehow that they are actually measuring this, they're sampling the same population basically?
Ooh.
That Mirza is taking a sample of 49 and 48 patients of their population they're studying, right? Whatever their setting is, if it's a single center or multi-center. And then they are sampling the 15 and 18, and then they are sampling the 21 or 33 and 31 patients. But it's still the same country, same
No.
center.
Every study of these are multicentric, and more than 10 countries join this. But it's not relatively. It's all new therapeutic investigation, so there isn't any use for this combination therapy in a daily based practice. So it's only in a clinical trial phase right now.
Okay, but the question I wanted to ask is, did you somehow manage that they are all coming from the same paper, these outcomes, or they are just pooled like as if they were independent papers?
They wasn't published. I don't really understand. They wasn't published in the same paper. They are.
Just looking at this figure, that's all the information I have, right?
These two are subset of this.
So these are separate models, all separate models. Okay. So then the only thing is that it's a bit misleading that they are on the same axis.
Right. You said something that these are all multi-center international studies with such low patient numbers. Unbelievable.
Yes, but these are the first of these studies, so that's how they work out. If there are going to be some clinical relevant professional opinion in this field, maybe they will grow in the patient number. Like for the PARP inhibitors alone, the average patient number is around 500 per paper, and it's a well-studied field, and this one is a quite new one.
What you said, it's very nice, but it's everything known. You know, it's in the guidelines. You said in the conclusion that PARP inhibitors are an effective treatment option in newly diagnosed and recurrent ovarian cancer. We know it. It's in the guidelines.
Some percent of these results are known in the guidelines, but there wasn't any meta-analysis in the field which included every aspect of this therapy, like every therapeutic setting with the recurrent and newly diagnosed ovarian cancer, and divided in the different subgroups based on the molecular mutations. So that's the new. On the other hand, for the BRCA wild type patient, as I know, in the latest guideline, there isn't any recommendation. So for the BRCA mutated patients, it's obvious that they have to do this. They have to try this PARP inhibitor therapy as a maintenance. I agree with that totally. That's not a question, or not a big deal, and not a brand new thing. But in the other groups, it's not that.
You can try it.
Yes.
Okay. Thanks.
My question would be a connection for the previous one. When an ovarian cancer is diagnosed after a laparotomy or laparoscopy and has a histological result, and they select the patient to this PARP inhibitor therapy, what was the following up of these patients? What was the average follow-up time? What was the percentage of the second look laparotomies? How could they describe the digression of the disease?
Thank you for your question. In most of the trial, the follow-up time is around 2 years. But there are studies like the solo one, which is the original trial for the PARP inhibitors, and it has a 7-year follow-up. They published it in 2023 in January, and at the 7-year follow-up, that was the first study in ovarian cancer and in PARP inhibitors. At the 7-year follow-up, they find out that 67% of the patients treated with PARP inhibitors are still alive at 7 years, and compared to the placebo line, which is 40%, and 45% of the patients was disease-free at 7 years, and only compared to 22 or 23% with the placebo. These are huge results that are quite new and newer than these results, but it doesn't change it. And the other thing is the second look laparotomies are not really connected with our field, but I know that there is a big trial which came out last year with the second look laparotomy, and but I think they are not investigated with PARP inhibitors at the time. Like after the second look, secondary cytoradioactive laparotomies or laparotomies, there isn't a trial with PARP inhibitors therapy again.
Sorry for my questions. I'm a pediatrician, and the OB/GYN rotation was so far. And so for this advanced ovarian cancer patients, what is the first line treatment? I mean, do they undergo a kind of a surgery and then they get to receive this therapy with PARP inhibitors, or so this is the way how it goes.
The way is known for, I think, around 30 years. The first line is the surgery. The second line is the chemotherapy. Nowadays, and for the last 20 or 30 years, it was and it is platinum-based chemotherapy. And after that, it's as we talked about it before. After that, for the recurrent phase, for the recurrent setting, and now for the newly diagnosed setting too, after the chemotherapy, they start the maintenance therapy with PARP inhibitors. And now at this state of science, they do it for a 2-year period. After the surgery and the chemotherapy, they start the maintenance therapy for 2 years. That's the standard right now.
And are these therapies, I mean the PARP inhibitors and the VEGF, available for Hungarian women?
Yes, we use it. The combination is not yet.
Okay.
But the therapy with VEGF inhibitors was available before the PARP inhibitors, and now one PARP inhibitor, the olaparib, is available in Hungary too.
And what do you think? How will your results change the everyday practice? So, is there anything you are thinking different in the everyday clinical life?
The results are show that maybe it's a smaller part that it could change, but the main way that it could change it, that it shows that PARP inhibitors are good for the BRCA wild type patients too, and we have to find out is why. We got theories like the PARP inhibitor trapping for the DNA strand and these kind of theories, but we are not sure that this is the line where we have to go. And the other thing is the combination therapy with VEGF inhibitors and the previously mentioned immune checkpoint inhibitors.
What type of ovarian cancer were examined in your studies?
Thank you for your question. The most frequent ovarian cancer histological type is epithelial ovarian cancer, and in over 90% of the cases, it's in these trials they investigated in advanced ovarian cancer, which almost every time means high-grade serous ovarian cancer.